as more people join, please, you're encouraged. If you have not done so, Hannah joining from Ethiopia. Now we are complete. The entire Africa has been covered. Ethiopia, Eastern Africa. This is good. It already promises to be a great session. We have a presentation from all. Please, if you're joining from the United States, from Europe, let us know. Welcome from Akko Job Primary Health Center. Okay, we would welcome more people as they join. Kemi from General Hospital Fakojaya, welcome. Okay, so you're all welcome once again to Project Aisha tele-education session titled Special Conditions in Pregnancy 3, Rhesus Incompatibility in Pregnancy. Next slide, please. Okay, please, just a few housekeeping and few information before we get into the session. Project Aisha leverages the ECHO model. We collect registration, participation, questions and answers, chat comments, and poll responses for our programs. So what it means is your individual data will be kept confidential and handled by authorized personnel only. These data may be used for reports, maps, communication, surveys, quality assurance, evaluation, research, and to inform new initiatives. Next slide. Okay, just few more housekeeping information to help us maximize this session, which promises to be very great. We encourage you, please put on your camera if your data bandwidth can permit. Put on your camera so we can see your wonderful, beautiful faces. We have a very seasoned subject expert that will take us on the topic. So just to make sure it is much more, please use the raise hand feature in Zoom when you want to speak. The facilitator will unmute you when you need to speak. When we get to a period of questions and answers, then pending that, please use the chat function for any questions or to provide any feedback you may have. Please know that we're here to provide you with technical support through the session. If you have any challenges, just let us know in the chat area and then someone will attend to you. Next slide. Please take note, this Zoom session will be recorded. At the end of the session, we'll be sharing a PDF version of the slides so that you can always refer back to the teachings, which promises to be very enlightening. So like I mentioned, this tele-education session is a Project Aisha tele-education session, but hosted by MDOC. Project Aisha has the overarching goal to have zero preventable deaths for women and children during childbirth. The project is implemented currently in 2 states in Nigeria, Lagos and Kaduna states, and is being implemented by a consortium of partners funded by MSD for Mothers with active support from both the Lagos state and the Kaduna state government. Next slide. The consortium, like I mentioned, comprises 4 organizations combining over 50 years of experience and expertise, history of collaboration and cooperation, bring together complementary skills and competencies to the project. The 4 implementing partners include Health Strategy and Delivery Foundation, Ingress Health Partners, MDOG, and then the Institute for Healthcare Improvement. We have many of our implementing facilities joining us today from the different locations in both Lagos and Kaduna. Next slide. Just a recap of our subject matter experts that have been guiding us, especially with curation of topics, guidance on the flow of the sessions, and also helping us with, like I mentioned, the topics, subject matter experts that were also engaged to ensure that we're delivering valuable capacity development information to not just our patients, but healthcare workers and policymakers. Next slide. More about our subject matter expert. Next slide. So just a quick agenda. We've done welcome introductions guidelines. We will just go through a few quality of care review highlights. Then we'll jump into our pre-quiz, more information on that. And then subject matter expert who has already joined us will take us through the topic special condition in pregnancy 3, Rhesus Incompatibility in pregnancy. And then we'll have a case presentation from one of our implementing facilities. We'll get expert insight and response to the case presentation from the subject matter expert. Then we'll give room for questions and answers and some discussions. We have our post quiz, we'll take some reactions, announcements, and then we'll wrap up the session. Next slide. Okay, just a quick overview of MDOC. We're very glad that we're hosting this session. MDOC is a digital health social enterprise focused on optimizing the end-to-end self-care experience for people with health needs by harnessing quality improvement methodologies, data, behavioral science, and technology. Our goal is to ensure that people live healthier, happier, more productive lives in Africa. This support that we provide is done through our 4-pillar approach, through virtual coaching, utilizing our omni-channel complete health app, and then through digital healthcare navigation directory, navihealth.ai, which we use to connect healthcare consumers with healthcare facilities and providers across Nigeria. And then also our MDOC Quality Network, which is also supporting to host this session, where we utilize tele-education sessions to basically grow the capacity development of healthcare workers, policymakers, and patients. And then we also have our community nudge hubs. These 4-pillar approaches we utilize to ensure that people are healthier, happier, and more productive in Africa. If you have your phone, we encourage you go to our Navi, go to Google Play Store and download the Complete Health app, and then sign up to one or more of our programs. You will be assigned a multidisciplinary team of health coaches who provide the support. So whether regular, whether chronic health conditions, we're there to provide 24/7 holistic support. Next slide. And then our Navia.ai, a web application, please go to www.navia.ai and register, sign up. You can search for any facility closest to you, either by service, either by condition. And then the Navia.ai platform also gives you the ability as a healthcare consumer in Nigeria to lend your voice towards improving quality within our facilities. Next slide. So we encourage as many people as possible to sign up as a patient.
Enter navihealth.ai into your web browser. Next, click on the sign up button you can find below. Choose from one of the options to register either as a patient, facility, or healthcare provider. Input your details. You can use a registered phone number or email address of choice. But please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the finish button to be redirected to input the 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth.
Good afternoon. I think Solomon has been bumped off. I think he's having internet connections. So just to proceed, we will be giving out CPD points. I'm sorry, can you hear me? Am I audible? Sorry,
yes, we can, Astrida.
Yes,
Yes,
Astrida. Yeah.
Thanks so much. So in partnership with the Sub-Saharan Health Solutions of Nigeria, SHSN, we are offering continuous professional development points, which we will contact you after the session, and your names will be used to receive this. So your full name, your surname, your FOIA number, and your qualifications, of course. And of course, T's and C's apply, but we will be reaching out to you with regards to these points. Thank you.
Okay, sorry, can everyone hear?
Yes, I can hear you now.
Yes.
Okay, sorry, we had a technical glitch. Thank you. These are some of the insights from women's feedback on the quality of care that they have received on the project, also utilizing NaviHealth.ai. Please to the next slide because of time. Okay, so we will launch the pre-quiz immediately. You will have it pop up on your screen. Just a set of few questions that you're supposed to provide answers to, just to know that the pre-quiz is just to allow us to assess the impact of the session. No one's answers or performance will be aired, analyzed, or shown. It's just strictly for us to know how well the session has impacted on you. So please, can we go on and launch the pre-quiz immediately? Please go ahead, launch the pre-quiz. If you do not see, if it doesn't pop up on your screen, you could go to the bottom right corner of the application on your phone, click the three dots, and it would appear. Okay, so we've launched the pre-quiz. Just a set of 8 questions, not just true, false, to tell us. You don't need to access any material or anything, just from your own knowledge. Select the answers that you think is true, and then click submit. Let's go ahead and then quickly go through the pre-quiz questions. Okay, thank you. We see the answers are coming in. Please, if you do not see the pre-quiz poll which has been launched, please let us know in the chat. If you can't see, please let us know in the chat. We'll have just 3 minutes to complete this the poll, and then we can get into the session proper. Yes, let's have the answers coming. Let's have it coming. Thank you to everyone currently attempting the poll and sending in their answers. We just want to assess our knowledge before the session. At the end of the training, we'll also carry out a post quiz so that we can assess how well this session has really impacted it. This is how we co-design with the people that we serve. Let's go ahead, get the answers coming in. If you cannot see the poll, please let us know. Okay. Thank you to everyone who has submitted. Please go on. We'll have a lot of people. Please join, take the pre-quiz, submit. We just want to know how well you understand the topic before our expert in the house will go ahead and deliver her lecture. Let's have it coming in. Thank you to everyone who has submitted. Thank you. Let's keep it coming. Let's keep it coming. Thank you, Lawrence. Thank you, Lawrence. Thank you, everyone who is done. Please go ahead if you're here to do this. If you're just joining, we are just attempting some questions, pre-quiz, just to assess a background knowledge about the topic before we go into the session. Like I said, no one's the responses is just for appraisal purposes. At the end of the day, we'll still be able to get answers to the questions. So just go ahead and answer. We'll be closing the poll in about 1 minute. Thank you, and thank you, Hannah. Thank you, Chizaba. We've seen lots of people have responded. If you have not, please go ahead and do so. Thank you, Ariel Bosede. Thank you, Ishako Hassan. Thank you, everyone. Thank you. This has been wonderful so far in terms of participation from everyone. Okay. So we have an information. Health workers who would like to get CPD points can email their details to mqn@myemdoc.com. The details we need are your name, surname, phone number, and qualifications. So you can see the information in the chat for those who want this to contribute towards the continuous professional development by earning CPD points. Please leverage the information in the chat area. Okay, and so we will be closing out in a matter of seconds. If you have not answered the pre-quiz, please, you still have a few seconds to do that. Very simple questions, true, false, true, false, true, false. And then let's get right into it. Okay. Okay, thank you to everyone who has responded to the previous questions. Okay, thank you very much to everyone. So we can now end the pre-quiz. We'll be ending the pre-quiz in 10, 9, 8, 7, 6, 5, Or okay, just I think those who were supposed to end, they were faster than my counting. Thank you. Next slide, please. Okay, I'll use the mic to my colleague. Go ahead and introduce our subject matter expert. Okay, I'm introducing Dr. Mrs. Olofolake Abosede Oni, a consultant obstetrician and gynecologist, MBBS, FWACS, ART, PGD. Dr. Mrs. Olofolake Abosede Oni is a renowned consultant, obstetrician, and gynecologist. She's a fellow of the West African College of Surgeons and holds a postgraduate diploma in assisted reproductive technology and reproductive medicine from the University of Schwelz-Holstein-Kiel, Germany. She also has diplomas in project management, in global health and leadership management in health from the University of Washington. Dr. Oni currently heads the Department of Gynecology Unit, Kelina Hospital, and serves as a visiting gynecologist to Medform and Fox Club hospitals in Abuja, FCT, Nigeria, where she leads efforts to strengthen maternal care systems and outcomes. Ladies and gentlemen, our distinguished listeners, let's join our hands together and welcome our distinguished subject matter experts. Please, I want to see hand claps, hand claps. You can use the icon, you can put it in the chat area. If you don't clap, she would not start. If you don't clap, she would not start. If you not clap, she will not start. Let's make her feel very, very welcome and excited to hear her walk us through the subject matter. Thank you so much for joining us, Dr. Oni. Please, over to you.
Good afternoon, everyone. Excited to be here. Can you all hear me?
Yes, we can hear you, but it would be good if you could project more.
So good afternoon, everyone, once again. Thank you so much for inviting me over. Rhesus immunization is an important topic that coincidentally I've fallen in love with in my training years. And so when I was reached out, I was just wondering, now, this is interesting, Rhesus immunization again. All right, so we will be talking about an important obstetric entity that has been a cause of increased neonatal loss and fetal losses. And though it's highly preventable, by the time we are done, we will actually have a full idea of what Rhesus immunization is all about. All right, so next slide, please. Okay, so Rhesus incompatibility in pregnancy is a topic. It's also referred to as immunization or Rhesus disease. Basically, my outline, which I will go through, will involve include introduction, pathophysiology, what a sensitizing event will be or can be, complications, how do we manage patients that have Rhesus incompatibility, whether they are sensitized or not, how to prevent Rhesus immunization, some common guidelines that will help us in our practice, and then we'll conclude. So now, you can see a beautiful picture here that shows a baby there, and then we can also see the baby being connected to the umbilical cord, and we can see blood vessels in full. Just picture that in your mind. So let's go to the next slide. So, Rhesus examination is responsible for a lot of problems in babies. Typically, Ajax fetalis, hemolytic disease of the newborn, stillbirth, severe jaundice in units that would require phototherapy, exchange blood transfusion in a bid to prevent
Hello, Dr.
cancer from
Oni.
occurring.
Sorry. Hello, Dr. Oni. Can you hear me? Yes. So your voice is low, and so we're struggling a bit to hear you.
Is it better now?
Yes, it's much more better.
Much better. Okay. All right. So maybe I'll just try to speak out louder.
Yes, please.
Okay. All right. So I did say previously that rhesus incompatibility is the same thing as rhesus immunization and rhesus disease. And it's actually one of the causes of ajax fetalis in rhesuses. And then it's a common cause of stillbirth, uterine growth restriction, uterine fetal death. And in some babies, they could come down with severe jaundice. And then, with severe jaundice, babies are born needing phototherapy, exchange blood transfusion in a bid to prevent cancerous from occurring and its debilitating consequences. So by way of definition, it's actually the development of rhesus antibodies in a rhesus D negative mother when she's exposed to a rhesus D antigen. So now picture a mother whose blood group is maybe O negative, AB negative, A negative, or B negative. And then she's exposed to the rhesus D antigen, and then she produces antibodies against it. So we know that a rhesus D negative person ideally doesn't have any rhesus antigen. So if she gets exposed to rhesus D antigen, the normal response is to produce antibodies. Now, epidemiology. Rhesus D negative blood group is most prevalent among the Basque population. About 30 to 35% of them. These people reside around Spain and some other parts of the European world. Now, this is followed by the United States that have 15%. The Asians actually low to 5%. African blacks 4%, and then in Nigeria, in a study that was carried out in Enugu, about 4.5% of women actually had D negative. Now, the incidence of IT immunization is Can you hear me now?
It's low, it has gone, and I think there are times when it comes high, then it goes low again.
Okay, is it better now?
Yes, it's better.
Okay, because my loudspeakers are on maximum already, and I don't know how much more I can push them. Okay, so is it a little bit better now?
Yes, it is.
Okay, all right, thank you. Sorry about that. So I just mentioned about the fact that rhesus incompatibility is the same thing as IT immunization. I talked about the fact that women who are D negative, when they get exposed to the rhesus D antigen, they could get sensitized by producing antibodies. Now, I talked about the epidemiology. Okay, so as regards to being tiny, you may need to speak to the admin, please. They can make it bigger for you. So I talked about the epidemiology, that the Black population have the highest incidence, and then we have a low incidence in Blacks. Nigeria is about 4.5%. Now, how did we coin the word rhesus? This was found first in the rhesus monkey, and then the rhesus factor in human beings is located on chromosome 1, short arm of chromosome 1, on the locus 34 to 36. Now, the rhesus blood system actually is made up of two other letters. We have the C, the capital letter C, small letter C, capital letter E, small letter E, and then just a single capital letter D. So it's actually a blood system, but the rhesus D is the most immunogenic of all of them, and is responsible for most of the IT immunization or incompatibility that would eventually stumble on that would occur when a woman is pregnant. Now, rhesus D positive individuals can either be heterozygous. When I say heterozygous, that means they have mixed capital letter D, small letter d, or they could be homozygous. That is two capital letter D. Now, the heterozygous are more. They occupy about, respond to about 55%, while the homozygous about 45%. Now, in actual sense, Patients who are D positive are Rhesus Z positive. Once they have that gene on the short term of chromosome 1, then they are born with Rhesus Z positive blood group. Now, for those who do not have it, actually, in actual sense, there is no small letter D, but it's just to connote a negativity in the Rhesus Z. So scientific-wise, there's really no small letter D in quotes. So absence of the capital letter D connotes that you are negative. But just for simplicity's sake and for us to understand what we are discussing, I've denoted the D antigen. Thank you for highlighting that. So now, why do we have to talk about resource immunization? Well, it's been found out that without intervention, without giving immunoglobulin, then we realize that a lot of women would become sensitized, and then this results in problems in their babies. Sensitization can range from 15% to 45%. In the first trimester, we have about 15% of mothers being sensitized, and then about the third trimester, we could have as high as 45% being sensitized. So we can imagine when a woman is sensitized in the third trimester. So that means that when the next pregnancy, we would have a lot of problems in subsequent babies. However, nature being good, God being good, it's not always this clinical picture in a lot of people. We have a lot of resource negative mothers who I know some of us might have come in contact with. They never got immunoglobulin, and yet they're not sensitized. No antibodies to show for the fact that they've never been exposed to the resource antigen. And now there's something we call attenuating factors. We have 30% of patients who are not responders. They don't respond, no matter the antigenic response that they're exposed to. We also have the ABA incompatibility group. That is a mother who is O negative, married to a man who's either A or B positive. There's already a form of hemolysis occurring. So before the plane will recognize a D positive antigen to produce antibodies against, the retinal system would have mopped it up immediately. So the mother does not get exposed to the resource antigen, and then the baby is safe, and there's really no problem with that. Okay, so the risk of sensitization now actually depends largely upon 3 factors. The first one is the volume of transplacental hemorrhage. Now, how much of blood seeps into this maternal circulation? I found out that in the first trimester, as early as the first trimester, we find out that in 5% or 15% of patients, that we have red blood cells in that maternal circulation already. So if you have a lot of bleeding coming from the baby into the maternal circulation, of course, the mother will be more sensitized, and somebody has a small amount of bleeding. Now, the extent of the maternal immune response, if the mother is able to mount an exuberant immune response to the amount of fetal maternal hemorrhage that occurs, then the higher the chances of sensitization. Then we talked about the concurrent presence of ABA. Next slide, please. So basically, the pathophysiology of Rhesus Z immunoglobulin, Rhesus Z IT immunization and incompatibility occurring. We talked about it briefly, but let me expatiate on it. Now, a Rhesus Z mother itself, she lacks the Rhesus Z antigen, and then she gets pregnant, or she gets a partner is Rhesus Z positive, and she gets pregnant for this partner. And the baby also takes after the father's blood group and has a Rhesus Z positive blood group. And this baby is nestled in the mother's womb. And then we had mentioned previously that we have antigens or fetal red cells getting into the maternal circulation. And then when this occurs, at this initial antigenic response or challenge to the mother system, the mother produces antibodies in response to this challenge. The antibody that is produced in the form of IgM. IgM is a glycoprotein which is has a high molecular weight. So it's too large to cross the maternal phase. It's just too large to cross. So because it can't cross into the through the placenta, then the first baby is spared. So though she has a Rhesus Z positive baby, but there's no sensitization, and the baby is just fine and okay. But when we now have a second antigenic challenge, usually during the second pregnancy or subsequent pregnancies, the memory B cells that have been produced in the mother system become primed again. and then they produce the IgG, which is a smaller glycoprotein, and then this actually is able to diffuse through the placenta. And then when it diffuses through the placenta, this gets to the fetus, and then, sorry?
Please go ahead. Let's go ahead. Yes, okay. Please.
All right, so this gets to the fetus, and then it binds to the fetal red blood cells. Let's not forget that these fetal red blood cells actually contain Rhesus D. So this antibody comes, binds to the fetal red blood cells, and once this happens, it results in hemolysis. An antigen antibody complex forms, and when this complex gets formed, it results in hemolysis, and then once the red blood cell gets hemolyzed, you can imagine this antibody response coming into the fetal circulation, the paternal circulation, frequently depending on the fetal maternal hemorrhage that we got exposed to, or the antibody reaction or response that the mother produces, and then this gets into the fetus, and then this continues to produce hemolysis. With continuous hemolysis, this results in anemia, and then this anemia could either be mild or severe, depending on how much of hemolysis that we are dealing with. All right, next slide. Okay, so the severity of hemolytic disease is related to the maternal antibody titer, the affinity of the red blood cell, affinity of the antibody rather to the red blood cell membrane, and then the ability of this fetus to compensate for this blood hemolysis that's actually happening. Because we know that the fetal red cells are being broken down, and a lot of times the baby is trying to produce more red cells in response to this hemolysis. Some babies are able to do this in a fantastic way, and then they're able to escape, and then they're just fine. How about some babies succumb, and then they have severe hemolytic disease? All right. Now, another mechanism of sensitization, and this is about the commonest form of sensitization, is like an inadvertent transfusion of a mother with positive blood. Let's say, for instance, a mother gets involved in an accident. Nobody knows what her blood group is, or she's unconscious at the time when she's being resuscitated and being transfused. And then the next thing somebody comes to do is the O positive blood. So with the O positive blood in her system, this results in production of antibodies. And then when she gets pregnant, then the problem starts. Okay, now, in the absence of any of these antigenic responses, blood transfusion, or pregnancies, or sensitizing events, now there are some things to call what we call sensitizing events. Now, sensitizing events, go to the next slide, please. Sensitizing events are events that actually occur in pregnancy that could actually predispose a woman to respond exuberantly or to produce antibodies. Now, when the fetal cells get into the maternal circulation, we cannot, the dangerous thing about resuscitation is that we cannot even tell the amount of blood. We don't have a sensitizing volume input. We found out that even 0.1 ml of fetal blood can actually sensitize. And meanwhile, some just don't get sensitized for any reason at all. So this becomes a problem for us. However, when we are sensitizing events occurring, this further increases the chances of a mother being sensitized and then producing antibodies. This sensitizing event can be spontaneous or induced abortion. Spontaneous abortion after 10 to 12 weeks, actually, because it's been found out that less than that gestational age, the amount of fetal maternal hemorrhage occurs is very, very minimal and may not provoke antibody production. Antepartum hemorrhage like placenta previa, abrupto placenta, vesa previa, all of these things can actually stimulate the mother to produce antibodies. Deliveries. Every woman that gets pregnant hopes to have the baby one day. Either she has a vaginal delivery or a cesarean section. So all of these are sensitizing events to that mother. Or she delivers a baby, and then the placenta gets stuck, and we have to do a manual removal of placenta. All of these have been found to increase the risk of what we call fetal maternal hemorrhage. That's the amount of fetal blood that gets into the circulation, further increasing the risk of antibody formation. Molar pregnancies have also been found to be a sensitizing event. Molar pregnancies can either be partial molar pregnancies or complete molar pregnancies. Partial molar pregnancies, of course, we have fetal tissue being produced. So this has been found to be a sensitizing event. Complete molar, there's no fetal tissue. So there may not be any sensitizing event in quote at that point. For the sake of safety, we just clarify both of them. Either is a complete or partial, especially in clients like ours, where sometimes it may be difficult to differentiate between a partial molar pregnancy or a complete. It may be safer to just recognize as a sensitizing event and act accordingly. Abdominal trauma, like she falls over, she starts bleeding while she's pregnant, or she has a vehicular accident, or external cephalic version, which is not as popular as it used to be before anymore, or a baby dies in utero. A baby that dies in utero, a lot of times we could have problems with blood circulation. That could even be the reason why the baby died. Or maybe the baby had abruptive, or the mother had abruptive placenta and it's high left. We already know that we already have blood loss. So all of this could be sensitizing events. Then later treatment of twin transfusion syndrome. In twin transfusion syndrome, we have a twin transfusing the other twin because the bigger twin has a higher hematocrit and the smaller twin is dying. So the bigger twin starts transfusing the smaller twin. So by the time I try to do a laser treatment to ablate the connecting or communicating vessels within the placenta or the cord of this baby, this can also sensitize the mother. Next slide. So what are the complications of rhesus immunization? Now, rhesus immunization is found to cause a lot of problems in mothers, especially for those who have sensitized and those who have lost babies before, especially those who have had hydrocephalus in the past. This can result in recurrent miscarriages, recurrent stillbirth. There's increased need for investigations in pregnancies. In a mother who cannot even afford to take care of herself in pregnancy, now she's being told, oh, you need to pay more money for investigations. That drains our pocket. When the baby now comes, there's severe hyperbilirubinemia resulting in cancerous when the basal ganglia gets thin. Part of the pathophysiology, by the time the red blood cells are increasing into the fetal cells, and the antibody increases into the fetal cells, and we have the antigen antibody complex being produced, and the retroendothelial system mops it out of the system. These fetuses become anemic. So a lot of times too, while this hemolysis is occurring, we have bilirubin being produced in the fetus. In all cases, the mother is able to excrete this out for the baby, but sometimes, we have spillage into, or we have this bilirubin spilling into this fetal saturation, which is the mother's saturation is not able to handle completely sometimes. So in this situation, this bilirubin starts getting bound to albumin, and then albumin is able to take it out. But unfortunately, albumin could get to a point whereby it reaches its binding limit. It can no longer bind to the bilirubin anymore. And bilirubin is fat soluble. It's not water soluble. So unfortunately, this could actually get into the neurons, which are highly lipid soluble. And then this sends the basal ganglia and then causes cancerous in these babies when they are born, because their liver is not enough or matured enough to metabolize the bilirubin that is put into their system. Now, this is also called fetal anemia. When fetal anemia occurs, sometimes, a lot of times you could have IUG, actually which is moderate or severe anemia, and sometimes you would also need intrauterine transfusion in the mother, just to ensure that the blood is being broken down, so we can also replace it back to. Now, hydrocephalus can occur, which is actually the worst of all the complications, whereby we have fluid accumulating in a lot of tissues, the baby is edematous, and then sometimes the baby dies or is born stillborn. So at the point of delivery too, there's increasing for phototherapy, exchange blood transfusion, which can be very traumatic for mothers. So next slide. Next slide, please. So now, what do? We talked about the pathophysiology, about the complications that can occur in rhesus incompatibility or IT immunization. What we do is dependent on whether the pregnancy is sensitized or is a non-sensitized pregnancy. In non-sensitized pregnancy, it simply means that there is no antibody production. That means that the mother is because D negative, but there has been no antigenic challenge. Or there has been an antigenic challenge, but she did not produce antibodies antibodies against this antigenic challenge. So what do we do? At the fourth presentation, what do we do for this patient? We must repeat their blood group. She tells you, oh, I'm O negative. We're like, okay, that's fine, that's fine. Let's do a repeat. We repeat first and we confirm that she's truly D negative. Now, when she's D negative, the next thing you want to do is to do an enzyme poop test. We want to find out if we have any antibodies there. Now, if this is negative, at 28 weeks, we repeat the enzyme poop test again. If she's negative again, then we'll give her Rhesus D immunoglobulin. Now, the Rhesus D immunoglobulin that we give can either be a low dose or high dose. If you give a high dose of D immunoglobulin, that is 1,500 international units, which is equivalent to 300 micrograms of immunoglobulin, Rhesus D immunoglobulin. Now, the both guidelines quote that if you give a high dose of Rhesus D immunoglobulin, that is 1,500 international at 28 weeks, you may not need to give at 34 weeks. But if you give a low dose, that is, you give 500 international units at 28 weeks, at 34 weeks, please repeat another 500 international units, as long as the enzyme poop test remains negative. So, patient comes in, we find our blood group, we do the ICT. If it's negative at 28 weeks, we give a Rhesus D immunoglobulin. Either we give a high dose between 28 and 34 weeks, or we give 2 low doses of 500 international units, 500 international units at 28 weeks and at 34 weeks. Now, this dose should suffice most times by the time it's delivery. Now, for this mother, when she delivers, the next thing we want to do is to check the baby's blood group. If the baby is D positive, we want to give a post-delivery or postpartum Rhesus D immunoglobulin. Now, this is going to help to mop up whatever fetal maternal hemorrhage that occurs at the point of delivery. However, in 0.4% of cases, we may have a large fetal maternal hemorrhage occurring, and this value may not be enough. So you may now need an additional dose of Rhesus D immunoglobulin. Now, the additional dose we give can be found out by detecting how much of fetal maternal hemorrhage has occurred. Now, this fetal maternal hemorrhage that has occurred can be, I'm actually partly shouting into the speakers. Can you hear me better now? Is it better now?
Yeah. Yes, it's better.
Okay. So the speaker is right in front of me. I'm actually speaking into it. So sorry about that, please. All right. So to find out the amount of fetal maternal hemorrhage following delivery, if you feel that there was a lot of blood loss, take for instance, postpartum hemorrhage occurred, and you're worried that, oh, the amount of immunoglobulin that I've given may not be enough to mop up whatever fetal red cells that are gotten into the maternal circulation. So we do a clear-better test. Now, this helps us to determine the excess amount or total amount of blood cells that have been the mother has been exposed to. The 1,500 international units that you give is enough to mop up 30 mils of fetal red cells. If you now do your clear-better test, you will find out that, oh, this woman had probably 40 mils of fetal red cells in maternal circulation. What is the next thing we do? For each mil of fetal red cells, we will give 125 international units of Rhesus D immunoglobulin, in addition to the 1,005 that are given initially. Are we clear on that point? So if we have an excess amount of fetal maternal hemorrhage, what we need to do is to do a clear-better test to help us identify. It's also called an anti-deletion test. It's also to identify the excess amount of blood loss that the baby has been or the mother has been exposed to. And so it actually calculates the fetal red cells in the maternal circulation and multiplies it by 50. That way, we are able to identify the fetal red cells that have escaped into the maternal circulation. So I said that 1,500 international units of your Rhesus D immunoglobulin is enough to cover 30 mils of fetal red cells. So if you do your clear-better test and you realize that the blood loss is probably 35 or 40, for each additional mil of blood loss you identify, you will give 125 international units or 20 micrograms of Rhesus D immunoglobulin in addition to what you have given before. So that would help mop up the excess blood in maternal circulation. Now, if a mother at 34 or 35 weeks has a Rhesus D, has an indirect test done, and she's reactive, you do not need to give your ROGAM or Rhesus immunoglobulin anymore because she's already sensitized. Why? What you are trying to prevent has already happened. So there's no point giving the Rhesus immunoglobulin. So what do? We manage her as a sensitized patient. So for sensitized pregnancies, there are two ways to manage them. And the management is dependent, or rather, the management is dependent on whether there's been a previously affected fetus or no previously affected fetus. Next slide, please. So a sensitized pregnancy with no previously affected fetus. What do we do in this situation? We do our indirect home test. That is to confirm that she has been sensitized, because indirect home test is what will let you know whether she has been sensitized or not. If she has been sensitized, it will come out positive. So let's say a woman who is, this is a second or third pregnancy, walks into your consulting room and she says, oh, I'm O negative. I did not receive ROGAM during my last delivery, or I received and I was fine, or whatever she tells you. And then you say, okay, it's fine. You do your indirect home test and it comes out positive. The next thing you need to explain to her, madam, you are sensitized already. Your body has produced antibodies against the Rhesus antigen, and you explain the problems the baby may have, and then what you want to do to limit or minimize these complications that may occur. So what do we do next? We begin our antibody titer assay at 20 weeks gestation. That is if she presents very early. But if she does not present early, anytime she presents, we begin our antibody titer. So we're looking for an antibody titer. We want to ensure that the ratio is less than 1:16. Studies in laboratories have found out that at this level, the risk of fetal anemia and hydrocephalus occurring is very low when antibody titer remains less than 1:16. Now, at this stage, if it remains that the risk is less than 10%, but the higher you go in your antibody titer, the higher the risk of fetal anemia and hydrocephalus occurring. Now, so if the antibody titer now gets to 1:16 or greater than 1:16, the next thing to do is to do an amniocentesis. That is to collect samples of the amniotic fluid under ultrasound guidelines from the amniotic cavity. And then we subject it to photospectrometry at the optical density of 450 nanometers, and we plot this against the gestational age of this woman. Now, this is done by using the Lilith curve. By using the Lilith curve is a curve that helps us to classify babies whose mothers have an high antibody titer above 1:16. So it classifies them into mild, moderate, and severe, depending on the zone that they are in. If they are in a mild zone, or in zone 1 rather, that is a mildly affected fetus that has a low risk for developing hydrocephalus. If they are in zone 2, that's a moderately affected fetus that has a very high chance of developing jaundice following delivery. Babies that are in zone 3 have a very high risk of developing what we call hydrocephalus, as explained previously. Now, at this stage, you might need to then aim to deliver. So for babies that are in mild or in zone 1, let's go to the next slide, please. For babies that are in zone 1, these are mildly affected fetuses. So what do? We don't do much. We just repeat our amniocentesis every 2 weeks. And then we keep checking. Is this baby still in zone 1? Or has the baby progressed to zone 2? Is the baby going to zone 3? And then so we just keep checking and keep checking and checking and checking until, what is our aim? Deliver close to 10. So that the baby is matured as much as possible to have an extrauterine life. Now, for babies that are in zone 2, now these are babies that are moderately affected. Now, in some centers, they no longer do amniocentesis because of the risk of being a sensitizing event, although the risk is very minimal, but there's still a small chance that condition could actually occur amniocentesis. So in those centers, we do Doppler velocimetry of the middle cerebral artery. And then we check for when the peak volume gets to 1.5 median of multiples of the median, rather. So if a fetus has a normal middle cerebral artery Doppler, without an amniocentesis done, that baby is also fine. That's a mildly affected baby. You just continue to monitor and manage and deliver close to 10. Now, if you have a baby who is already nearing 1.5 multiples of the median on the middle cerebral artery, that's a moderately affected baby. So you want to keep repeating this test every 1 to 2 weeks. And once lung maturity is confirmed, once baby's lung is confirmed, we do not need to wait till close to 10. We deliver this baby. Because once the lung is matured, any other problem, most problems are mild problems that can be resolved by our perinatologists, by our pediatricians. So our aim is to deliver as soon as possible. Now, for a baby that falls in zone 3 on the Lilly score, or the middle cerebral artery Doppler velocimetry is greater than 1.5 multiples of the median, or you find out on your scan that eye drop fetalis has occurred. This is a late presentation. These babies need intervention to survive. If not, if nothing is done, within the next 7 to 10 days, this baby will die. So that is why it's important. We must identify these fetuses. We must know them. We must be able to do all of these procedures to find out, oh, this fetus is nearing this. This is what we have to do to salvage this fetus. So if the fetus has gotten to zone 3, the next thing we want to do is to do a cardiocentesis. That is to put in a specialized needle under ultrasound guidance and to put it into the umbilical vein and take blood samples. What are we looking for in the blood sample? We want to know what the baby's blood group is. Okay, so multiple MOM is multiples of the median, please. Thank you. All right, so for cardiocentesis, what are we trying to do? We are trying to get the blood level of that baby. Has this baby undergone hemolysis so much that baby cannot survive in peritoneum anymore? The person needs to know the blood group of this baby, especially the ABO and then the Rhesus group. Can you hear me? And the second thing is to know what the blood level is, to know whether the baby is anemic or not. So this would also help us to also transfuse this baby as necessary. There are 2 ways to transfuse this baby, or these babies that are involved. Either we do a transperitoneal transfusion, which is no longer as popular as before. What we need to do is to get the O negative blood with cytomegalovirus negative that has been irradiated, leukocyte depleted packed cells, are transfused into the baby's peritoneal cavity, waiting for the diaphragm to absorb this blood. However, this has been found to cause problems in some babies that are already compromised, from eye drop fetalis. So you do not want to do this. So the better thing to do now is actually to do an umbilical vein transfusion. Can we go to the next slide, please? All right. So when we do an umbilical vein transfusion, we know exactly how much of blood volume that we are giving. Now, I want to talk about the role of ultrasound in babies like this. Ultrasound is fantastic in helping us in managing recessive babies with incompatibility. It helps us in biopsy profile, our amniotic fluid index, the weight of the baby. But when it comes in determining a pre-hydropic baby, the ultrasound is notoriously unreliable, unfortunately. The reason is because just before a baby becomes hydropic, a significantly anemic fetus may not even have any sign at all on the scan. You may just feel this baby is fine. You may miss it completely, except for those that have been very used to doing scans. Some early symptoms or signs a baby could become hydropic very soon when we notice polyhydramnios in that baby. Polyhydramnios, the normal amniotic fluid index we expect in healthy babies range between 8 to 25 or 10 to 25, depending on the claims that we are practicing. Now, if the AFI is greater than 25, that's polyhydramnios. Now, when we notice skin thickening, and then we have early ascites, especially around the fetal bladder, or the placenta becomes thickened. These are early signs of edema of the placenta. We need to do something. Ultrasonic measurements of the liver and spleen have also been suggested as aids in predicting anemia in non-hydropic fetuses, but they lack sensitivity and specificity. So what am I saying? Do not be too reliant on your ultrasound. The ultrasound will help you, but even if the ultrasound is not showing a pre-hydropic baby, and you have done a cardiocentesis, but usually cardiocentesis is not done by any regular obstetrician or gynecologist, please. Generally be done by perinatologists. If you cannot handle it in your facility, please refer to a facility where the mother can get this done. If your photosynthesis shows that fetal anemia, do not rely on your scan. Please go ahead and transfuse. Now, amniocentesis retains its role as a primary modality of assessing the fetus because the amniocentesis contains hemolytic products that are excreted from the kidneys and the lungs, including bilirubin, which we have talked about. Now, this is actually excreted into the amniotic fluid, so you can actually get the bilirubin. Let me go to the next slide, please. So how do we prevent ABO incompatibility? The first thing we want to do for our mothers are precious. Our mothers are important. Yes. So what do we do? How do we prevent and reduce incompatibility and ICU immunizations during their pregnancy? The first thing we can do to help mothers or intending mothers is to determine their ABO group. All women must know what their ABO group is and their resource group. Because if she does not know, and she does not tell healthcare workers in an advanced public, she needs to be transfused quickly under an emergency situation, she's conscious, she will inadvertently be transfused a resource D positive blood. And these are cause problems in her already. So that's the very first thing we need to do. We must identify what our blood group is, please. The second thing is for every sensitizing event that has been mentioned before, we must administer resource D immunoglobulin. Whether it is the low dose you want to give or the high dose, please give resource D immunoglobulin. It will go a long way in preventing her from producing antibodies that may kill her subsequent babies. Studies have shown that the rate of sensitization has been reduced to 1.5% by giving her resource D immunoglobulin. If you do not give resource D immunoglobulin, the rate of sensitization is about 16 to 20%. So that means for almost 25%, or in 50% of cases, we would have about sensitization of point in these women. And we know what that connotes to their babies when they get sensitized. So please give your resource D immunoglobulin. If you are not sure, please give resource D. You will never be wrong in giving resource D immunoglobulin. The next thing is our mothers must, when they are pregnant, they must benefit from antenatal fetal surveillance for all pregnant women. Please, we need to, if you don't have that in a facility, always refer mothers for antenatal fetal surveillance. Let know how these babies are doing. And eventually, you don't know what their blood group is. And you do your antenatal surveillance, the baby looks unusual. That may just be a giveaway to let us know that there's a problem going on somewhere. Now, instead of a lot of times in developed world, what they do sometimes, or a lot of times rather, is once the blood group of the mother is known and she is pregnant, during that pregnancy, we do a percutaneous umbilical blood sampling to know what the baby's blood group is. If the baby is O negative or either A negative or AB negative, then you really do not need to give resource D immunoglobulin. That means there's no chance or risk of sensitization in that pregnancy. However, because of the sensitizing event, now the whole world actually moving away from amniocentesis in detecting the blood group of this baby. So what do they do now? They do what we call NIPT. That's a non-invasive pregnancy testing, checking for the cell-free DNA that can be detected in the blood cells of the mother right from the first trimester. And they can accurately predict what the blood group of this baby will be. Once they know what the blood group of this baby is, they know, oh, we need to give this, we need to give that, or we don't need to give anything at all. So this actually helps drastically avoid unnecessary administration of resource D immunoglobulin subsequently in that pregnancy. Now, routine administration of resource D immunoglobulin mothers have also drastically reduced incidence ICU immunization. I've talked about this already. Now, routine administration at 28 weeks reduced postpartum immune prophylactic failure. I would explain what this means. Now, if a mother comes in and her ICT is non-reactive, so what do we, or is negative rather, at this stage, what do we do for these mothers? We give our resource D immunoglobulin. Now, at the point of delivery, the resource D immunoglobulin is also repeated again if the baby is resource D positive. However, it's been found out that for mothers who receive the resource D immunoglobulin antepartum at 28 weeks, the chances of having a prophylactic failure with your postpartum prophylaxis is further reduced about 0.1%. So that means the rate is so low. So when you put 1,000 women together, maybe just one of them will be sensitized, as opposed to having 2 in 100 women being sensitized. So that tells us that giving antenatal resource immunoglobulin goes a long way in ensuring that our mothers do not get sensitized in pregnancy. Also, in emergency cases, as a rule of thumb, let us always remember as obstetrician clinicians that, or even as relations of mothers who are O negative, tell them that please, or whatever blue negative, that please give O negative blood. Do not give a positive blood so that you do not sensitize these women inadvertently. However, in a situation where we now have an inadvertent transfusion of Rhesus positive blood to a mother, we should give a Rhesus immunoglobulin IV. It is more effective when a mother inadvertently is transfused with blood that is B positive. If you give IV, it is found to be more effective than to give it IM. Next slide, please. So we have our guidelines. Now, these guidelines are actually, if we're not looking at all our guidelines, we realize that all of these guidelines are saying similar things, but the difference between these guidelines is talking about the dose to give, when to give, when not to give, depending on the studies that have been done in their own environment. And so the broader guidelines serve to guide their own practice in their country. Now, Bingo came up with an ICM, they made a joint statement and came up with a guideline as regards when to give the Rhesus immunoglobulin, who to give it to, and what dose to give. Now, the high priority recommendation is that we must determine the maternal resource factor early in pregnancy so that we can detect the Rhesus negative mothers. And then once we do that, we should also check for the umbilical blood sampling to know what the baby's blood group is. If the baby is D positive, then we should give antenatal Rhesus immunoglobulin at 28 weeks. Following delivery of those mothers, if the baby is D positive, 72 hours within delivery, we should give a repeat dose of Rhesus immunoglobulin, as long as they have not been sensitized. The recommendation here is to use a dose of 500 international units. However, if it is affordable, 1,500 international units can be given, because we know that 1,500 international units will mop up 30 mils of fetal red cells that the mother gets exposed to if she gets to that amount, while 500 will not get to that point. All right, so that's about, for 500 international units, that's about 10 mils is covered for 500 international units. Now, the middle priority is that routine anti-D prophylaxis during pregnancies should be given anywhere between 28 and 34 weeks. So that means you can choose to give at 28 weeks, that is by FIGO or ICM joint statement. You can give at 30 weeks, 32 weeks, 34 weeks, but just ensure that you give your antenatal prophylaxis within this timeline. What I'm saying about this timeline, most sensitizations will occur in the third trimester. 45% of sensitizations will occur in the third trimester. So that is why our target is to give this immunoglobulin at this gestational age. Now, after a surgical abortion, like our DNCs, manual aspiration, or an ectopic pregnancy has occurred at all gestational ages, or a spontaneous miscarriage that occurs after 10 weeks, which will give 500 international units of Rhesus immunoglobulin. Now, for patients that had abdominal trauma, vehicle accident, external cephalic invasion, or baby dies in utero, we should also give our Rhesus immunoglobulin. And we should do a clear vector test to assess the extract amount of beta red cells that have escaped into the maternal circulation. I've already talked a whole lot about this test previously, and we should give the additional doses as necessary. Low priority following amniocentesis, chronic disease sampling, or extensive evaluation, where we know that the risk of sensitization may be very low, we can give 500 international units. Now, what does WHO say? WHO guideline recommends administering the anti-D immunoglobulin to resource negative, non-sensitized women. The emphasis is on non-sensitized. If a woman has an indirect home test that is reactive already, do not give your immunoglobulin because they're just wasting it if you give. Now, resource negative, non-sensitized within 72 hours of delivery, then give your resource immunoglobulin, either your 500 international units or 1,500 international units, as the case may be. Next slide. Now, we have a recommendation by the British Committee for Standards in Hematology, which is the acronym. That is what BCSH means. Now, it's a whole long guideline, but I'll try to paraphrase as much as possible. It says, following potentially sensitizing events, anti-D immunoglobulin should be administered as soon as possible, always within 72 hours of the event. If unmet, can be given up to 10 days. Now, it may come to your mind, why must I give within 72 hours? When the study was done, when resource immunoglobulin was first manufactured in the 1960s, when it was realized that it can actually be used to reduce IT immunization, it was first tested in prisoners. And these prisoners, when the researchers go to the prison, they only allow the researchers to come to the prison every 3 days to test. You know, they go there, oh, somebody has delivered this negative, they go give the immunoglobulin within 3 days. They cannot go back there the following day to check if whatever they are giving is sufficient enough. They asked for another 3 days because this is a prison yard. The regular people were free, did not allow themselves to be used in the study. So it was prisoners that were used at that time. So 72 hours, which is equal to 3 days, is an artifact of that study. However, researches and studies now have shown that you can actually give up to 10 days, sometimes 28 days. So if you catch a woman following delivery, who probably you forgot to give your Rogam for whatever reason, or you did not forget, but Rogam was not just available due to whatever reasons, availability or cost implication, and she comes within 28 days or 10 days, please go ahead and give your resource immunoglobulin. It will really, really help this woman. Now, in pregnancies less than 12 weeks gestation, anti-D immunoglobulin prophylaxis is only indicated following ectopic pregnancies and molar pregnancies. I've already talked about this. Why? Because if a spontaneous miscarriage occurs, the risk of sensitization is very, very mild. Although I have colleagues who still give that, let's just avoid whatever we can, as long as the patient can afford it. Now, for potentially sensitizing events between 12 and 20 weeks, a minimum dose of 250 international units must be administered within 72 hours. So that means if a sensitizing event occurs, please, let's give our immunoglobulin. Now, for potentially sensitizing events after 20 weeks, we'll give 500 international units within 72 hours. After 20, at 10, yes, we give our 1,500 international units. Let's go to the next slide, please. So now, what do we do with the babies when the babies are born? So after delivery, what do we do to these babies? So we check their blood group, we check their resource D negative status. We want to know what their blood group, we already mentioned all of this. We want to know what their blood group is, what their resource status, we check their bilirubin level, and then the pediatrician continues to upwards manage while we face the mother. All right, so resource immunization is one condition with a universal impact, albeit with a good prognosis if managed properly. Prevention is the goal. Thank you for listening, everyone.
Thank you so much, Dr. Oni, for the presentation. Thank you very much. It was really educative and comprehensive. I think most of the questions that were being asked, I could see the answers in the presentation, but we'll still have some time to go over them.
Okay. So this presentation So we have a case presentation here of a patient that was managed at Meron Primary Health Center in Lagos. Next slide, please. She's a 32-year-old, her name is Miss Oti. She's a 32-year-old married trader who is a secondary school certificate holder. She was Bravida 2, para 1 plus 0. Now she's para 2 plus 0, 2 alive. She presented with abdominal pain that mimics uterine contractions, which started at 4 hours prior to presentation. The contractions or the pain started 4 hours prior to presentation. They were label-like, intermittent, regular contractions that were increasing in intensity and duration. There was no bleeding. Next slide. So our last delivery was 2022, so she had the baby alive. The birth weight of the baby was 3 kilograms. And then it was spontaneous vaginal delivery. The baby cried immediately after birth, and then local lasted for about 12 days. It was an essentially normal delivery. She attained menarche at 14 years. Her cycle was initially irregular, which is not unusual for most people when they start, but it became normal. And then presently she bleeds for 4 days in a 28-day cycle. Her flow is moderate. She had initially moderate to severe dysmenorrhea, but now she has mild dysmenorrhea following delivery. Sometimes she has occasional clots present. Next slide. All right, so she lives with her husband, and she and her husband are both business people. No issue of alcohol or tobacco intake, no issue of allergies, transfusion, no issue of surgeries, and no known chronic medical illness. Next slide. So at booking, she had done a serology, retroviral screening, hepatitis screening, and they were all negative. Her blood group was found to be O negative. Her genotype was AA. The urinalysis was fine. So the assessment of a Rhesus negative mother in labor was made. Next slide. So advisors at presentation, her blood pressure was 119/70. Her pulse was 82 beats per minute. There was a single fetus. Vaginal examination, she was already 6 cm dilated. She was already in the active state. She was having about 3 contractions in 10 minutes that lasted about 20 seconds. And she was encouraged to do breathing exercises to distract her from the labor pain. She was counseled. She had been counseled previously for the Rhesus Incompatibility program because it's readily available here, and she confirmed that she had fulfilled it. At about 2 a.m., she was fully dilated, and then she was delivered of a life-giving newborn at 2:10 a.m. And then oxytocin was given over the mother's abdomen. Placenta was delivered via controlled contraction, and baby was kept warm, cleaned and kept warm. The estimated blood loss was 200 ml. And post-delivery blood pressure 110. Over 7 centimeters of mercury. The baby's weight was 2.9 kilograms. Everything was extremely normal. She received Logam. That is 300 micrograms, which is equivalent to 1,500 international units. Next slide. All right, so that's like the case presentation. So we just learned the case of this was D negative pregnancy and then how she was managed in labor. So I have a little addition to this case presentation. I noticed that no antenatal or no antepartum globulin was given to this patient. Either she was not counseled for it or she didn't have it on well. We really cannot tell. Then the case presentation too, we were a little bit silent as regards the timing she came in. How many hours? Or what time rather did she come into the hospital? How do we know when labor gets prolonged? The only thing we have was she presented with 4 hours history of labor pains, and she was admitted at 2 a.m. She was fully dilated. So we really don't have the time interval of how long she actually spent in labor. And then the administration of oxytocin on the maternal abdomen, I was wondering the rationale for that. Why wasn't oxytocin given an anterior side? Why did we go for the anterior abdomen? We could have, well, yes, we have muscles, but oxytocin is given IM, not subcutaneous. When I'm giving oxytocin subcutaneous, the rate of absorption, we have problems with that. So preferably, please, the WHO recommendation is to give IM oxytocin on the anterior side, please, not on the maternal abdomen. All right, so the questions, do we have other questions? Okay, I think I can see some questions.
Thank you so much, Dr. Oni. Thank you so much. Thank you. Just for the interest of time, I don't know if some of the questions have already been answered, but I'll just read some of them, and then you could provide some answers. The first one says, when Rhesus incompatibility is diagnosed, what is the first thing to do by the health worker or by the mother? That's the first. Then another one says, how do we manage in areas we cannot do clear birth care tests? Then there's another that says, please give the full meaning of your abbreviations, e.g. MON. Then we have, I'll read this one and then you can take before I look at others. Then this one says, can you clarify the timing and dosage of RH immunoglobulin administration? And are there any new recommendations based on recent studies?
Okay, so let me look at the questions that I hear. I'm sorry, I couldn't catch up with the rate at which you were writing, but I will just quickly look at the ones that I hear. So when Rhesus incompatibility is diagnosed, what is the first thing to do by the healthcare worker or by the mother? So the first thing you want to do, you already know that. How did they even make this diagnosis for Rhesus when we will talk about in the presentation? So what do we want to do first and foremost as a healthcare worker and the mother? So you want to know the antibody titer. That's the first thing to do. You want to know how much of antibody titer or how much of antibodies that this mother producing. And that is what we can get through your amniocentesis or your middle cerebral artery. Now, if we know what the antibody titer is like, we talked about the fact that if it's one, the ideal is 1:16 or less. If the antibody titer is less than 1:16, then we know that this baby is safe. But once the antibody titer gets higher than this, let me rephrase this. The first thing you want to do is to do an antibody titer, and that is gotten from the mother's blood. Now, we keep checking this on and on and on. As long as it's less than 1:16, the baby is fine, and we really do not need to do anything. But once the antibody titer goes beyond 1:16, the next thing you want to do is to do your amniocentesis or the middle cerebral artery Doppler to find out what zone do you want to keep this baby. Are you keeping it in zone 1 or zone 2 or zone 3? And this will now determine how we manage this patient. Now, the truth is, when we have a healthcare worker, it depends on the qualification of the healthcare worker that will determine how much we can do. In primary healthcare centers, once there's sensitization, please refer. Because the things that you need to do as regards the antibody titer, the amniocentesis, middle cerebral artery Doppler, you will not be able to do it in that center, except if you have a visiting physician that can do all of that. But that will be too cumbersome. So please, I think you may need to refer. But if you're in a center, we have a gynecologist who can do, we have a good lab backup where you can do your antibody titer to be able to find out how much antibody mother has produced. We can do amniocentesis. Oh, beautiful. You can retain the patient's fertility. So the next question is, how can you clarify the timing and dosage of Rhesus immunoglobulin administration? Now, I mentioned this during the presentation, that within 72 hours of delivery, we should give your Rhesus immunoglobulin. For antepartum, varies, depending on the guideline that you are going with. But irrespective of the guideline you are going with, WHO, NHS, PCSH, FIGO, ICM, they have all said you must give immunoglobulin at 28 weeks. Now, the next question may be, Do I want to give a low dose or a high dose? If I'm giving a high dose, at 28 weeks, 1,500 international units, and the woman is covered. You don't need to give again at 34 weeks. But if you give a low dose, 100 international units, please, at 34 weeks, give a repeat dose to cover this baby, or to cover the mother rather, so that we reduce the risk of sensitization as much as possible. Now, there are other things that could also make you give. It's important, please, to note this. Even though you are giving your immunoglobulin at 28 weeks, if this woman bleeds again and has a sensitizing event, you must give your repeat dose. So you may not give a lower dose. Maybe 500 international units, maybe she had a threatening miscarriage, or maybe she had an abdominal trauma or external cephalic version. But what is important is, as a person, at 28 weeks, between 28 weeks and 34 weeks, you must give antenatal prophylaxis. In absence of sensitizing event, if there are sensitizing event, you must repeat your dose, because that will make your postpartum prophylaxis more efficacious. I hope I have answered that. Okay, so the next thing is, please, how do we assess the multiples of the median for NTA? That is done by the obstetrician and the sonographers, please. Now, during your Doppler, that is how we're able to identify, depending on the kind of ultrasound machine you have. Our ultrasound machine, especially if you're using a GE-enabled ultrasound, like the solution series. Perfect, beautiful for checking your peak to solid volume, your middle cerebral artery. You can actually identify your middle cerebral artery. Once you get to the intraventricular plane, you will pick up your middle cerebral artery using your color Doppler. Once you see that, you can see a tracing of your Doppler velocimetry and pick up a peak to solid volume. Your machine can also help you calculate that practically. But this may be difficult for you to understand if you are not looking at the machine presently. So sensors offer amniotic sensing. Yes, we have sensors in Abuja and Lagos that actually do amniotic sensing. Particularly, Lutz has some partnership with sensors that do amniotic sensing. In Abuja, in Mr. Premier, yes, we have sensors for amniotic sensing where they can actually do all of this and at national hospitals. So we can actually get that done in this center. So what facilities do we use to confirm long maturity in Nigeria? Now, in Nigeria, to confirm our long maturity in Nigeria, usually we leave it to the lab physician. So sorry about that. Or the lab scientists, actually. Most times we obstetricians do not usually confirm long maturity. So we take our samples, we send to them, and then they're able to assay for fibronectin. Once we can assay for our fibronectin, then we know that yes, long maturity has been confirmed. Also some what is it called now? Some glycoprotein or that we can actually assay for, but I'm not sure we can actually do that presently in Nigeria. So how does the cell-free DNA have a role in detecting baby's blood group? Beautiful. I've answered this during the presentation. What I actually mentioned there is that, we have fetal red cells escaping into the maternal circulation. So we have this escaping into the maternal circulation. So what we just do is we take, presently in Kelena Hospital, we partner with a company where we take blood samples. And then what do we do with this blood samples? We take about 30 mils of blood samples once the mother is 12 weeks pregnant. We take blood samples and then we send it to them. So what do they do for us? What do they do? Essentially what they do is to check. So from that from those cell-free DNA, they can pick up the baby's red cell and then they check the blood group. In fact, there are a whole lot of things that can be gotten from this cell-free DNA. We can check the chromosomal makeup of this baby. We can check what is it called? All these aneuploidies, chromosome abnormalities, the blood group, the genotype, the genders of this baby. We have a whole lot of things that can be done with this cell. But the problem there is the cost. But presently, if you are trying to convert from dollars to naira, it's about 850,000 naira presently. So the question now is, how do we balance the cost of giving the immunoglobulin twice than to do a fetal cell? So for couples that cannot afford it, so rather say, oh, let me buy the Rogam instead. And then we give. The cost of resourcing immunoglobulin depends on the brand you are using. The brand determines the cost that we use. So I may not be able to tell you what the cause of ROGAM is because, of course, when the hospital sources for ROGAM, we have to put a markup too. So I may not be able to say this is what the cause of ROGAM is presently. But if you go to probably pharmacies outside, they're looking about 120,000 naira and above, depending on what kind of pharmacy you're going to, depending on where they're sourcing it from. So that determines the cost of ROGAM.
Okay, thank you so much, Dr. Oni. In the interest of time, we're going to quickly take our post quiz, and then if we still have time, we can still come back to answer more questions. Thank you so much. So just before we go into the post quiz, just recapping what we said at the start of the session on continuous professional development. So MDoc, in partnership with Sub-Saharan Health Solutions Nigeria Limited, is offering continuing professional development CPD points for doctors in Nigeria attending our tele-education sessions. Please take note that this is a limited time offer. To apply, just send an email to mqn@mymdoc.com with your full name and, of course, plus your surname, a folio number, and qualifications. The training sessions are free for all participants. However, a CPD processing fee of 5,000 naira applies for those seeking certification. Please take note that only participants with significant attendance during the session will be eligible. Terms and conditions apply. Don't miss this opportunity to enhance your professional development. Okay, for the interest of time, please, next slide. So before we call our subject matter expert to provide answers to the post quiz, of course, anchoring on all the things we've learned in the last couple of minutes, more than an hour, please, the post quiz has been launched. The same way you answer the pre-quiz, please go ahead and answer the post quiz. It has been launched now. If you can't see it, let us know in the chat so we can guide you. It has been launched. You should see it covering your screen now. If you did not take the pre-quiz, no problem. Please go ahead and answer the post-quiz questions. You'll see the answers coming in already. We have just less than 3 minutes because of time constraint. We have less than 3 minutes to answer this. Participants joining on YouTube, the link will be shared with you. Please click on it and then answer the questions as well before we bring in Dr. Oni once again to provide answers to these questions. Please, let's go ahead. Thank you to everyone providing answers. You can see the answers coming in. Please, we do not have much time. We want to respect the time allotted for this session because we know many of us have other things to do. Please, let's quickly do this. You don't need to consult any material based on what you have learned from this session. Based on information shared by Dr. Oni on this session, please go ahead, attempt the questions. Like we said, no one's answers will be published. No one's identity will be published. It is not to say, oh, you did well, you didn't do well, you passed, you did not pass. The idea is for us to be able to measure knowledge gained from these sessions and to be sure that the session has been able to have the expected impact. As soon as the post quiz is ended, Dr. Oni will come in to provide answers to these questions. We're coming to the end of this amazing session. I have learned a lot. I do hope it's the same with everyone who has been on this session. We've had lots of participants, and of course, with the many questions we got, it's also evident that we were listening and we're gaining as we should. Keep the answers coming. Keep the answers coming. If you cannot see the question, okay, for example, I can't view my posters. So to the right-hand corner at the bottom of your screen, if you're joining from your phone, or your laptop, there are 3 dots there. So when you click the 3 dots, you see polls/quizzes, polls/quizzes, 3 dots to the bottom right of your screen. You have the 3 dots. You see more. Click on it, you see polls and quizzes. Click on that and it will be launched. Let's go ahead. Thank you. The answers are coming in. The answers are coming in. Thank you to everyone who has answered. Please go ahead. Whether if you did a pre-quiz or not, please go ahead and answer the questions. Go ahead and answer the questions. Thank you. We see the responses coming. We see them coming. Thank you to everyone. Thank you to everyone. Thank you to everyone. Let's keep them coming. Thank you to our participants in YouTube. We see you. We see you. Thank you. Thank you. Let's keep it coming. Let's keep it coming. So many people providing responses. This is great. This is great. This is great. This is great. If you have any issues, please let us know. Please let us know. While we're at it, thank you to Dr. Oni. She's also providing responses to some of the questions via the chat area. Thank you, everyone. Please let's keep them coming. Keep the responses coming. We'll be ending the poll shortly. We'll be ending the poll shortly. We'll be ending the poll shortly just so that Dr. Oni can quickly provide the responses and we can end the session. We have 1 minute to go. If you have not provided, if you've not answered, please go ahead and do so. Please go ahead and do so. We want to know how much you understand about this. No one's identity or responses will be shared or analyzed on an individual basis. It is just to measure the knowledge gained from this session. Thank you, Lawrence. Thank you to everyone who have answered. Thank you, thank you, thank you. Keep it coming, keep it coming, keep it coming, keep it coming, keep it coming. So we're ending the thank you, thank you, thank you. We see you. Thank you. This is great. 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 Okay, so we'll be ending the post quiz at a few seconds. I'll start my countdown. I'll start my countdown. I'll start my countdown. Okay, and the countdown has started. Yes, Lawrence, you know the correct answers to the quiz for knowledge sake. Exactly, you do that. You will know that as soon as we end the quiz, we will get into that. Okay, so we'll be ending the quiz in 10, 9, 8, 7, 6, 5, 4, 3, 2. Thank you to the last minute people answering. 2, 1. Thank you to everyone who has provided response. Thank you to everyone. We'll share the results now so that we can get answers to the questions. Okay, Dr. Oni, just so that we can quickly go through this. Okay, so the first question says the Rhesus D blood group is the least immunogenic among the Rhesus antigen blood system. True or false?
False.
Tony, we can hear you.
Okay, it's false because it's the most immunogenic. You know, I mentioned that the Rhesus blood group system is comprised of C, D, and E. C and E are silent. They're not really responsible for most ITO immunization. They could, but usually when you have a CDE, once the D is positive, that person is D positive. So D is actually the most immunogenic, not the least immunogenic.
Okay, thank you so much. So the correct answer will be false. Okay, so the second question says, I think.
You want me to go through all the quizzes? Let me go through all the questions.
Yes.
Okay, so for number two.
So, the second question says the production of immuno. Can you hear me?
Yes. Go ahead.
Okay. The production of immunoglobulin G is the first antibody response following exposure to Rhesus antigen. True or false?
So the answer is false because the first response is IgM, which I mentioned is a large molecular weight like a protein, so it can't diffuse to the placenta. Well, after its second antigenic response, having the second pregnancy, then we now have another antigen challenge again. Then the body produces IgG, which is smaller. That is the one that passes into the placenta and affects the baby. So IgM is the answer.
Okay, thank you. Fetal heart failure is an important etiology in the development of hydrops fetalis associated with Rhesus isoimmunization. True or false?
Okay. So that's false. The reason being that the etiology actually of hydrops fetalis, like mentioned during the presentation, is when the blood cells are destroyed following hemolysis and they are mopped up out of the endothelial system. The next thing that happens is the baby is trying to compensate with this blood to produce more blood cells. So by the time the baby can no longer sustain increased production of red blood cells, the liver is called into play, which is what we call the extramedullary hematopoiesis. The liver produces nucleated red blood cells, which are not typical normal cells, thereby destroying the normal architecture of the liver. Once the architecture of the liver is destroyed, albumin that is meant to bind to the bilirubin that is being produced from the hemolysis is also not being produced in adequate or sufficient amounts because the liver architecture has been destroyed. So bilirubin spills into the baby's circulation, we start having issues with bilirubin, which may actually happen into post-delivery phase. So the etiology of this hydrops fetalis is as long as albumin reduces, albumin increases oncotic pressure. When albumin gets out of the system, what happens? You escape into extracellular space, and we have the hydrops fetalis. So it's not a cardiac failure that actually becomes an etiology. It's actually the hepatocellular destruction following the extramedullary hematopoiesis. That's what actually causes all of these problems. Minus the placenta edema that occurs from also the antigen, antibody problems that we also have. So that's why it's false.
Okay, thank you so much, Tony. The third question says an important recommendation to reduce Rhesus incompatible pregnancies is for all attending mothers to have their blood groups ascertained. True or false?
Okay, so it's true. And the important, like I mentioned, the first thing we want to do for mothers, we need to know what their blood group is. If you know what their blood group is, and they can tell you when they're in emergency, they don't get chances with O positive blood. And then at the point of pregnancy, they can go, oh, I'm O negative or I'm B negative. Immediately you confirm to, and then you can do your ICT and give your results in the globulin. But if you don't know what the blood group is, you can't even start doing ICT. You can't even know globulin. So that's it.
Thank you. Question 5 says for Rhesus D negative mothers, a direct Coombs test is part of their blood workup at presentation. True or false?
The answer is indirect Coombs test, not direct Coombs test. Because no indirect context, you're not assessing the baby's blood cells directly. You're assessing the baby, you're using the mother to assess the baby. So it's an indirect context. But when the baby is born, you cannot do a direct context on the baby's blood. So that is why it is false. It's actually an indirect context, not direct context for the mother.
Okay, thank you so much. I hope we're taking note. Question 6, Rhesus D immunoglobulin must be given to mothers following a spontaneous miscarriage, irrespective of the gestational age the abortal process occurred. True or false?
So this is false. During the presentation, we talked about it that if the mother has a spontaneous miscarriage less than 10 weeks or 12 weeks, we don't want to bother. The risk of fetal maternal hemorrhage is minimal, very, very minimal. So in resource controlled environments where we don't have access to program, you may decide that, oh, let's give to people after 12 weeks instead of less than 12 weeks. So it's not an absolute indication to give at that gestational age. But after 10, 12 weeks, beautiful, you can give. Yes, because the fetal maternal hemorrhage is more at that time. So it's more beneficial for them.
Okay, thank you so much. For each ml of fetal red cell found in maternal circulation, 200 international units of Rhesus D immunoglobulin must be given. True or false?
It's false. It's 125 international units.
Okay. And last but not the least, administration of Rhesus D immunoglobulin after 72 hours following delivery or a sensitizing event is not helpful in preventing sensitization. True or false?
It's false. If there's anything we're going to leave here with, we must not forget this. That when a woman delivers, even if she does not have antenatal care with you, and she delivers and you find that her blood level is still negative, please give. If she has a sensitizing event, please give. Please, let's not forget that. That is like the core of this presentation. Thank you, everyone.
Okay, thank you so much. Can we give Dr. Oni a round of applause? Thank you so much. Thank you so much, Dr. Oni, for doing justice. I know we've learned a lot, lots of reactions, lots of questions in the chat. Thank you so much. We still have more questions coming in. Please, let's appreciate Dr. Oni in the chat. Go ahead. Please, more reactions, more reactions. This has been very, very engaging. This has been very engaging for myself. I had no idea whatsoever what Rhesus incompatibility in pregnancy was, but definitely much more enlightened. And I do hope that, especially for the sake of our partners, the men in the house, have gotten adequate knowledge with this. Thank you so much, Dr. Oni, for this wonderful session. We are going to, while we're sending our accolades to our subject matter expert, we're going to quickly launch a reaction survey, same way the post quiz came up. Please just take 1 minute or less, just 5 questions, let's know. It's already launched. Please go ahead, just give us answers, help us curate the sessions better, much more impactful. Let's see your reactions. Please go ahead, let's know. Just 5 questions, click. Just let us know how this session impacted you. How was it helpful? Let's just know how your general feeling around this. We really want to continue to serve our community better in delivering capacity development trainings that will continue to improve healthcare workers, improve patients, policymakers, and just ensuring that, like they often say, Africa know they carry last this time around. Please go ahead. More reactions coming in. Thank you so much. Please, everyone, go ahead. Thank you for sticking with us up till this time. We will be closing out this session. very, very, very shortly. So please go ahead. You can expect that we will share more information about these training slides to everyone who has participated, like we said, just so that you can have access to the materials and you can continue to learn. Thanks, Dr. Oni, for this wonderful presentation. I see you're even also engaging, providing answers to some of the questions in the chat. This is very, very remarkable. Thank you so much, Dr. Oni. Yes, please, can we still have some people who have not, if you can't see this reaction survey, please, the same way, go to the bottom right corner, you see three dots, click on it, it'll appear, and then let us know how well this session has impacted you. Please go ahead, more. We'll be ending it in the next 1 minute because of time. Thank you to everyone who has participated, who has responded to the reaction survey. We are very, very grateful. We do hope that when next more sessions will definitely be coming. You will also find time to join and learn. Don't forget the information around the CPD points. Send your full name, folio, and other information like we shared to mqn@mymdoc.com. We've also sent the reaction survey link to our participants on YouTube. Please, you can also click on the link and provide feedback on that. Thank you so much. We'll be ending the survey in the next 20 seconds. Please go ahead. Thank you. See more coming. Okay, so we just have 15 seconds. 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. Thank you to everyone who we're ending the poll now. Thank you so much for everyone who has been with us throughout this session on Rhesus Incompatibility in pregnancy, organized by MDOC, Project Aisha, and then hosted by MDOC. Don't forget to sign up on NaviHealth.ai. NaviHealth connects healthcare consumers to healthcare facilities and providers. So wherever you are, you're searching for any healthcare facility, you have no idea where you want to go to, just go to NaviHealth and then search for any facility. We encourage healthcare providers. If you're a doctor, please go to NaviHealth.ai and sign up as a provider. Allow patients find you more. Allow patients, the platform helps patients connect more to healthcare providers. Sign up, create your profile, let us know your specialty. If you're a gynecologist, a cardiologist, whatever kind of doctor that you are, whatever your specialty is, conditions you've treated, please update your profile so that when patients come on NaviHealth to search, they can easily find it. Please follow us on our social media platforms where we'll continue to share more information about future and upcoming tele-education sessions. Also, you can go to our YouTube channel at MDOC Healthcare and you'll see a list of all the sessions that we have had up to this time. So we have a huge archive of tele-education sessions that we have had before now. So take your time, go watch these videos and continue to learn as we're going to provide quality service in the Nigerian and African healthcare space. Follow us on Facebook, Instagram, Twitter, YouTube, LinkedIn. Once again, we want to thank Dr. Oluflake Abosede Oni. Thank you so much on behalf of MDOC and the Project Aisha Consortium. We are most grateful for coming on and helping us learn more about Rhesus Incompatibility in pregnancy. Thank you so much. We do hope when we call you next time, You also oblige our request. Yes, the information materials from this session will be shared to everyone who has attended. Please, you're not to send your email address here. Send it to mqn@myendog.com for those who are interested in the CPD points. Send your email, your full name, your folio to mqn@myendog.com. For everyone who attended the session, we have details of your email address, which you provided at registration. We will be sending you the session materials. Thank you so much to everyone. Thank you for being with us. Do enjoy the rest of your evening, and well done as we continue to provide quality healthcare to Nigerians and Africans. Do take care and bye-bye. Thank you. 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 Thank you.